All right, so we'll start our discussion with eosinophilic lung disease. So for eosinophilic lung disease, the possible definitions are pulmonary opacities with peripheral blood eosinophilia, lung tissue eosinophilia on biopsy, or increased eosinophils in bronchoalveolar lavage fluid. So those are the definitions of eosinophilic lung disease. So the eosinophil itself, there's usually more of these within the tissues than within the blood. So these are carried in the blood to epithelia exposed to the external environment, especially the respiratory, GI, and GU mucosa, and they contain enzymes that damage parasitic worms and modulate mast cell dependent hypersensitivity reactions. So these eosinophils are an important immune response to the external environment. So if I tell you that this patient has cough and fever, so we can see there's a consolidation here. He does have an elevated eosinophil count. So this, then we're thinking about some eosinophilic lung disease here. So here's our current chest x-ray, and a few days later, the x-ray looks like that. So what has changed?
There's resolution of that right-sided consolidation.
Right, so this consolidation looks like it resolved. Anything else change?
Is there an improvement in lymphadenopathy?
Well, there was no lymphadenopathy, it's just the tortuous aorta. Well, first is the follow-up chest x-ray normal?
The left looks like there's a new opacity.
Yeah, there's a new opacity here on the left side, possibly also here too, in the periphery of the right side. So we have these so-called fleeting consolidations that come and go in somebody with an elevated eosinophil count. What do we call this? What is this called? Which of the eosinophilic pneumonias is this?
Löffler's?
Yeah, so this is Löffler syndrome, okay? So you can see the consolidations here are peripheral on the CT scan. So simple pulmonary eosinophilia or Löffler syndrome, blood eosinophilia, mild pulmonary symptoms, usually symptoms present less than a month, migratory consolidations, they can clear, come back, and fleeting consolidations that may have a peripheral predominance. If you happen to get pathology, it shows the eosinophils and histiocytes within the alveolar spaces and in the alveolar walls. So this is called Löffler syndrome. It's thought that 2/3 of patients originally given this diagnosis probably had parasitic infections or drug reactions. In Löffler's original series, they may have had ascariasis, but in 1/3, the cause still remains unknown, and it's thought to represent a reaction to some unknown inciting agent. So the key is that you get these consolidations, they get better, symptoms resolve in a month, and the patients may have eosinophilia, bilateral transient migratory consolidations, often peripheral. Now, here's a case. This patient has cough for 6 weeks and a history of asthma, also has an elevated eosinophil count. What's abnormal on the chest radiograph? Yeah, so here we have peripheral consolidations. So what do we think this is? So this is chronic eosinophilic pneumonia. So here you can see the consolidations are peripheral there on the CT scan. So chronic eosinophilic pneumonia. So here we have chronic infiltration with the eosinophils, usually present, the symptoms are present for greater than a month. Can progress to respiratory failure, especially if diagnosis is delayed. Strong association with asthma. About 50% of these patients have asthma. So if we have peripheral consolidations, prolonged symptoms, patient with asthma, eosinophil, elevated eosinophil count, we can think of chronic eosinophilic pneumonia. So the importance of making the diagnosis is that there's a dramatic response to steroids. So these patients are treated with steroids and they get better rather quickly. So pulmonary symptoms, peripheral blood eosinophilia, peripheral consolidations on chest radiograph. There may be eosinophils in the BAL fluid if the patients have bronchoscopy, and rapid response to steroids. So it's said that some descriptions of this is a photographic negative of pulmonary edema, because the consolidations can have that peripheral distribution there. So they may remain chronic there, but these peripheral consolidations, you can think of chronic eosinophilic pneumonia. So here's a case, a patient had asthma, progressive dyspnea and cough for greater than a month. History of carpet remover, did not wear a mask, so that may have been the inciting agent. And you have these consolidations there on the chest radiograph, did have an elevated eosinophil count, elevated eosinophils in the BAL fluid, bronchoalveolar lavage fluid. It may not be obvious on the chest radiograph that the consolidations are peripheral, but you can see here on the CT scan that the consolidations are peripheral. So this patient was diagnosed with chronic eosinophilic pneumonia, was treated with steroids. 9 days later, you can see the rapid response. So it is important to mention this in your differential diagnosis, as these patients do respond rapidly to proper therapy. What parasite can give you consolidations like this, peripheral consolidations, and can be associated with eosinophilia? Ascariasis, right. The worms, those parasitic worms. So parasites, especially those that have the larval stages as worms with a migratory phase through the lung, as they migrate through the lung, they can result in pulmonary consolidations with elevated eosinophil counts. So those are the common worms in the United States. And they can give you those transient migratory or Löffler's-like consolidations on the chest radiograph. So I won't go through again the disgusting life cycle of these worms, but when they migrate through the lungs, you can develop consolidations and eosinophilia. Drug reactions can also be associated with eosinophilia. Some of the more common drugs that can give you eosinophil or eosinophilia-like syndromes because of drug reactions. So that is another consideration. Consolidations we can see with these drugs, hilar lymphadenopathy, that can be associated with the anti-seizure medications. Pleural effusion, we can see that with nitrofurantoin in interstitial lung disease, especially pulmonary fibrosis. You can also see with nitrofurantoin in methotrexate. So here's an example of drug reaction from methotrexate. You can see some peripheral consolidations. So this can also be associated with eosinophilia. This patient had consolidations, peripheral distribution, biopsy showed necrotizing vasculitis and tissue infiltration with eosinophils. What's the diagnosis?
Churg-Strauss.
Yes, so this is Churg-Strauss syndrome. Okay, so eosinophilic granulomatosis with polyangiitis. So it is associated with elevated ANCA levels, and these patients can have a necrotizing vasculitis. They can have consolidations in the lung. They can have eosinophilia. Asthma, marked peripheral eosinophilia, systemic vasculitis involving 2 or more extrapulmonary organs. That's the clinical triad for Churg-Strauss syndrome. There are diagnostic criteria for it, so I've given that to you in your handout. So with 4 of 6 criteria, 85% sensitivity, 99% specificity. So we can have necrotizing vasculitis, tissue infiltration with eosinophils, so-called extravascular granulomas or eosinophilic abscesses, because on pathology you have these centrally necrotic nodules of tightly packed eosinophils. So this may result from hypersensitivity reaction to some inhaled agent. There's an asthmatic phase, there's an eosinophilic phase, and then there's a vasculitic phase which can affect many organs, as I've listed them there. So we can have pulmonary involvement in up to 70% of patients. This can also give you consolidations like Löffler syndrome, sometimes like chronic eosinophilic pneumonia, and these patients can have peripheral eosinophilia. So they can have consolidations like that. On this CT, you can see some peripheral consolidations. So this is another one of those diseases that can give you consolidations and eosinophilia. Now, asthma also, the eosinophil is an important cell associated with asthma. That is the inflammatory cell that occurs along the airways. That's why we see parabronchial thickening in these patients with asthma. And these patients can also have eosinophils in the peripheral blood and also in the BAL fluid. So what do we see with asthmatics? In addition to the increased lung volumes, we can also see peribronchial thickening. And so that is from the infiltration around the bronchi with eosinophils in patients who are asthmatic. And so this peribronchial thickening we can also see on CT. We can also have mosaic attenuation because of these scattered regions of air trapping in patients with asthma. So if you do expiratory views, you can see the air trapping a little bit better on these asthmatic patients, but sometimes you can even see it on your inspiratory views, the mosaic attenuation from air trapping in asthmatics. So here's an example. On expiration, you can see the pronounced air trapping. And you can tell it's expiratory. The bowing of the trachea is always a nice clue that you have an expiratory view. So this patient has asthma. We look at the chest radiograph. What do we think? So why do you think there's left upper lobe atelectasis?
Because the hilum is elevated on that side.
Yes, so hilum's elevated on that side, always a good sign of volume loss. Also the diaphragm, right, is elevated. Do you see the left heart border?
No.
Why not?
There's also like lingular.
Yeah, so the lingular is part of the left upper lobe. And if you're looking for atelectasis, the lateral view, especially for left upper lobe atelectasis, the lateral view is very helpful here. So it shows you the major fissure that's deviated anteriorly. So all of this is the collapsed left upper lobe. And that's why we're losing the heart border. The lingular is part of the left upper lobe and part of this atelectasis. So why do we think this asthmatic then has atelectasis?
Mucus plug.
Mucus plugging, right? So it's going to be mucus plugging. And then when they cough up the mucus plug, everything goes back to normal. So atelectasis, lobar collapse is very common in patients who are asthmatic. Here's another asthmatic. What's abnormal here?
Like large areas of mucoid impaction and like tree and bud opacities.
Yeah, so we have tree and bud opacities, and we have these areas of mucoid impaction. So in an asthmatic who has these findings, what might we be thinking about?
ABPA.
ABPA, right. So notice the airways are also dilated here from the mucoid impaction. So allergic bronchopulmonary aspergillosis. So this occurs in asthmatics. They can have consolidations, atelectasis, bronchiectasis with mucoid impaction. This can also be associated with peripheral eosinophilia. So bronchiectasis in an asthmatic should make you consider allergic bronchopulmonary aspergillosis. Here's a milder case of peribronchial thickening and some mild bronchiectasis there from this asthmatic. And then the mucoid impaction also. So this all turns out to be regions of mucoid impaction. And what can also be characteristic of mucoid impaction with allergic bronchopulmonary aspergillosis is what?
Finger and glove. So,
What?
are you talking about finger and glove? Opacities, or-
Well, what about the attenuation here?
They're
It's higher in attenuation. You'd expect mucus plugging to be fluid attenuation or low attenuation. So high attenuation mucoid impaction can also be characteristic of allergic bronchopulmonary aspergillosis. This patient has a history of binge smoking, fever for 3 days, hypoxia, no peripheral eosinophilia, but on on BAL, there's 30% eosinophils. What are we talking about here? What is this? So which of the well, first of all, what's abnormal on the CT? On the CT we have what?
It looks like pulmonary edema.
Yeah, it looks like pulmonary edema. You have interlobular septal thickening, you have ground glass consolidations. It really looks like pulmonary edema. So which of the eosinophilic pneumonias gives you a picture that looks like pulmonary edema? What is that called? So that is acute eosinophilic pneumonia. So this can be a severe acute illness It's caused by some hypersensitivity reaction. Interestingly, it is also associated with binge smoking. So recruitment of eosinophils to the lung, the release of the eosinophil contents cause lung damage and looks like pulmonary edema. Gives you an appearance that resembles pulmonary edema. So on pathology, there will be an infiltration with the eosinophils. Usually there is no peripheral eosinophilia initially, but it may occur later on in the course of disease. There is no association with asthma, and it is associated, can be associated with binge smoking. So acute febrile illness can lead to hypoxic respiratory failure, elevated eosinophils, no other cause for it, and this is another one of these that really does respond well to steroids. So to make the diagnosis, you want to treat with steroids. So the radiologic findings all resemble pulmonary edema and interlobular septal thickening, consolidations, ground glass opacities, pleural effusions, really looks like pulmonary edema. So that is acute eosinophilic pneumonia. So this does not have a peripheral predominance of opacities as opposed to those other causes of eosinophilic pneumonia that we discussed. So here's another example, 28-year-old severe shortness of breath after a week of binge smoking. See all of these consolidations. This was another case of acute eosinophilic pneumonia. And after 3 days of steroids, you can see the rapid response to steroids in this patient. Very large eosinophil count. The MRI post-contrast, there's a T1 weighted double IRFSE. What's abnormal on the MR? So we have these nodules on the CT, but what's abnormal on the MR?
Filling defect in what?
Yeah, there's this filling defect in the left ventricle, right? So what do you think that filling defect is?
Thomas.
Yeah, this is a thrombus, and why does the patient have a thrombus in the left ventricle? This is post-GAD. Notice that there is this subendocardial region of enhancement, right? So what do we call this?
Löffler's endocarditis.
Yeah, this is Löffler's endocarditis. So it's associated with eosinophilia, high eosinophil levels. And so there's damage to the subendocardium from the eosinophils. That leads to this subendocardial fibrosis, and we see that as the subendocardial enhancement. And then that can also lead to the mural thrombi. That's a patient with Löffler's endocarditis. In this particular case, it was idiopathic hypereosinophilic syndrome. So these patients can have very high eosinophil counts. There's no real cause for it. Initially called eosinophilic leukemia because of the very high eosinophil counts of these patients. And this can result then in organ damage, especially to the heart, endocardial fibrosis and other types of damage to the heart. And it's also associated with thromboembolic diseases. Cornelia? Yeah, I'm giving conference right now. Right. So that's idiopathic hypereosinophilic syndrome. Can damage many organs. I've listed them for you. They're also in your handout. Most of the findings are due to heart failure because of the damage to the heart from this particular syndrome. What can be kind of interesting is they can develop these nodules in the lungs with ground glass halos. So these nodules may have these ground glass halos with them when they occur in the lungs in patients with this particular syndrome. Okay, so that's idiopathic hypereosinophilic syndrome. And then we touched on Löffler's endocarditis. Anybody with elevated eosinophils in the blood can develop damage to the heart and this Löffler's endocarditis, which can result in subendocardial fibrosis, this subendocardial enhancement, and mural thrombi. Okay, so that's Löffler's endocarditis. So these are the eosinophilic lung diseases that we have discussed and covered. The differential for peripheral consolidations and eosinophilia, Löffler syndrome, chronic eosinophilic pneumonia, parasitic infections, drug reactions, Churg-Strauss syndrome. Those are the things to think about. But what about the differential for peripheral consolidations? So we can see that with eosinophilic pneumonia. You can see it with COVID, of course. COVID can give you peripheral consolidations. Of course, that's not going to give you eosinophilia. What else can give you peripheral consolidations?
Organizing pneumonia.
Yeah, so organizing pneumonia. So fever, cough, no eosinophilia. This is another disease that responds to steroids, peripheral consolidations. That's organizing pneumonia, right? That's an interstitial lung disease, cryptogenic organizing pneumonia. That can also give you peripheral consolidations. Cough, shortness of breath, no eosinophilia. What other interstitial lung disease can give you peripheral ground glass opacities like that? What do we call this? This, by the way, is also associated with smoking. This is DIP, discriminative interstitial pneumonitis. So this can also give you peripheral consolidations. They tend to be ground glass. This is associated with smoking, so that's DIP. Okay? Patient's acutely short of breath and has this chest radiograph. What's abnormal?
Peripheral opacity.
Yeah, you have a peripheral opacity here. Anything else abnormal?
Peripheral opacity.
Yeah, that right hilum looks pretty juicy, right? So it's a plump right hilum. So how do you put those findings together?
It's like PE with Hampton's.
Yeah, so that's a pulmonary infarct, right? So pulmonary embolism with a pulmonary infarct here, and then that's a Hampton's hump. So pulmonary infarcts from PE, these can also give you peripheral consolidations, right? That's what we would expect to see with pulmonary infarct. Shortness of breath, these upper lobe kind of opacities, what can do this? Oh, whenever you have upper lobe
TB.
TB, certainly. You always have to think about TB, right? What other disease can also give you upper lobe opacities? Silicosis, that tends to give you interstitial opacities. These are more alveolar. Sarcoid, right? Sarcoid's also in your differential, can look like TB at times, but sarcoid can also give you airspace disease, especially in an upper lung distribution. So your differential for peripheral consolidations, eosinophilic pneumonia, COVID, COP, DIP, infarcts, alveolar sarcoid, all of those can give you peripheral consolidation. So moving on to pulmonary hemorrhage, as we continue our discussion of airspace disease, the triad for pulmonary hemorrhage, hemoptysis, anemia, and consolidation. So if you have consolidation, they can be ground glass. They can be very subtle consolidations. So hemoptysis is the key. If we have hemoptysis and consolidations on CT scan, then we can think pulmonary hemorrhage. If I tell you this patient has hemoptysis and kidney failure, has consolidations like that on the chest radiograph, we would think about
Good pasture.
yeah, good pasture syndrome, right? So with good pastures, these pulmonary renal syndromes, good pastures is one of them. There are others that can also be associated with renal damage, right? The good pastures is the one we always think about. So antiglomerular basement membrane disease. So that antibody reacts not only with the kidneys, but also against the basement membrane, and that can lead to pulmonary hemorrhage. So pulmonary hemorrhage, glomerulonephritis, and antiglomerular basement membrane antibodies, okay? So they cross-react with the lung basement membrane, and that results in the hemorrhage within the lung. These patients may also be anemic. So consolidations from the pulmonary hemorrhage, they can resolve rather rapidly in patients with good pasture syndrome and immunofluorescence looking for the fluorescent antibodies there. Okay, so that's good pastures. If I tell you this patient has hemoptysis and elevated P ankle levels, consolidations on the CT. So what disorder are we thinking about here?
Microscopic polyangiitis.
This is microscopic polyangiitis, right? So here with microscopic polyangiitis, this is a small vessel vasculitis. They can have fevers, and about a third of these patients can develop diffuse pulmonary hemorrhage. Majority of them are ANCA positive, especially with the P ANCA. This patient has consolidations from pulmonary hemorrhage, sinusitis, elevated C ANCA. What are we talking about here? What's that?
Granulomatous with polyangiitis.
Yeah, granulomatosis or polyangiitis. So that's going to be Wegener's or GPA. So all of these can be associated with pulmonary hemorrhage. And the ankle levels specifically, these can also help in terms of differentiating one from another. So ankle-positive microscopic polyangiitis. Good pastures, Wegener's. So this is a necrotizing granulomatous vasculitis, can involve the respiratory tract. This can also result in pulmonary hemorrhage in some patients. There can be limited forms, about 10% of the time it only involves the lung without renal or other systemic involvement. So we look for the elevated ankle levels, which especially the C ankle, which can be helpful in making the diagnosis in these cases. So these patients can have opacities. We discussed this when we talked about cavitary lesions. They can have nodules and cavitary lesions with Wegener's granulomatosis, so they can have cavitary lesions. They can also have renal issues. And they can also develop pulmonary hemorrhage. So areas of ground glass opacity in these patients may represent pulmonary hemorrhage. Okay?
So if we were like differentiating that from microscopic, they would basically have to give you, like, they would have to show you cavitation or.
Well, if you had the
show you
cavitation, but
sinusitis.
right, the sinusitis, so we're talking about what can help us radiologically, so the sinusitis would help. But they're going to look at the ankle levels too to try to characterize, what the exact underlying disease is. Now, there are other diseases that can also be associated with pulmonary hemorrhage. SLE can do it. Other immune complex vasculitides can also do it. So these can also be associated with pulmonary hemorrhage. There's a disorder called idiopathic pulmonary hemosiderosis. So this is diffuse pulmonary hemorrhage without renal or immunological abnormalities. This tends to affect children. It's the most common cause of diffuse pulmonary hemorrhage in children. So these patients will have consolidations from pulmonary hemorrhage. So pulmonary hemorrhage in children, you can think of diffuse pulmonary hemosiderosis. Now, I've also given you in your handout all kinds of other things that can also that can be associated with pulmonary hemorrhage, from anticoagulation and DIC to all these other things, drugs that can also be associated with pulmonary hemorrhage. Interestingly, penicillamine, used to treat lead poisoning and rheumatoid arthritis, can also be associated with pulmonary hemorrhage. And then acute lung injury, of course, we've seen cases of trauma where we can have pulmonary hemorrhage. Necrotizing pneumonias, ARDS, all of these can also be associated with pulmonary hemorrhage. And in immunocompromised patients, leukemia, infections, Kaposi's, these can also be associated with pulmonary hemorrhage. So your list of all the various things that can cause pulmonary hemorrhage, so we've kind of touched on some of these. So moving on to cells that can give you airspace disease, what primary lung neoplasms can be associated with airspace disease and air bronchograms? Yeah, so what used to be called bronchoalveolar carcinoma, what is it called now? Mucinous adenocarcinoma, mucin-producing adenocarcinoma. So that can give you airspace disease, right? So with chronic consolidation, invasive mucinous adenocarcinoma, this belongs in your differential also for chronic airspace disease, okay? Now, here's a patient with air bronchograms. It has these parenchymal opacities. What inflammatory disorder can do this? Notice that there are also these nodular opacities, nodules along the fissures, subpleural nodules. Not rheumatoid arthritis, no. And then here you have nodules that might be coalescing into this larger mass. Yeah, so that sign is called the galaxy sign, right? So this is sarcoid. So sarcoid can also give you airspace opacities like that. They tend to be upper lung predominant. They can be associated with air bronchograms, as in this case. So that is alveolar sarcoid. What's abnormal on this chest X-ray? Right, so we have airspace disease here in the right lower lobe. Anything else? I mean, you're looking at this x-ray, there's nothing else that bothers you here?
Mediastinum.
Yeah, look at that mediastinum. So what is all this stuff over here? Look at this. What do you think that is? Okay. So there you go. What do you think this is? So what was causing the mediastinal widening? Lymphadenopathy. Then here we have airspace disease. So what do we think this patient has? No. Mediastinal fibrosis, you look for calcified nodes. And why would you get airspace disease with that? Also, you'd look for, you would look for, SVC syndrome, etc. You told me this patient has a lot of lymphadenopathy here. So what are you thinking about? Lymphoma. This is a case of lymphoma. Lymphoma can also give you airspace disease. When lymphoma infiltrates the lung parenchyma, it can extend out from the lymph nodes into the lung. That's what we see with Hodgkin's lymphoma. With non-Hodgkin's lymphoma, you can get a lymphoma in the lung parenchyma itself. But lymphoma is an infiltrating neoplasm that can also be associated with air bronchograms and airspace disease. So we can get alveolar consolidations from lymphoma. So this is another neoplasm that can be associated with airspace disease, lymphoma. Okay. So invasive mucinous adenocarcinoma, lymphoma, alveolar sarcoid, all of these can give you airspace disease from infiltration by cells. So you should have no trouble with this. What are we looking at here? So we have ground glass opacities, right? What else? Well, what do you call this pattern? What's thickened here? Yeah, there's interlobular, this is crazy pain, right? So there's interlobular septal thickening and also intralobular septal thickening. You can see fine septa inside the pulmonary lobules. So this is crazy paving. So what gives you crazy paving? So pulmonary alveolar proteinosis. So put that together with this finding. What's the finding there? What's the arrow pointing to? There's a cavitary lesion. So how do you put that together with pulmonary alveolar proteinosis? Why would someone with pulmonary alveolar proteinosis have a cavitary lesion?
Could be paraneoplastic.
No. Are there infections that these patients are susceptible to? What infections? Can be any infection, right? But the infection that is mentioned is nocardiosis. Also aspergillosis can occur. But patients with pulmonary alveolar proteinosis are susceptible to nocardiosis infection. That can give you cavitary lesions in these patients. So protein pulmonary alveolar proteinosis. There's the primary form, and then there are secondary forms that you can get from massive exposure to silica. Patients with pneumocystis also develop an alveolar proteinosis, and it can be associated also with lymphoma, alveolar proteinosis. So large amount of proteinaceous material. So it's thought to occur impaired removal by macrophages of this surfactant-derived phospholipid. So they are susceptible with the primary form to all kinds of infections, especially nocardia and aspergillus. Okay? So they will have consolidations, might resemble pulmonary edema. What is said is that the chest x-ray looks a lot worse than the patient. So the chest x-ray could look really bad, but the patient may not be as short of breath as you might imagine based on the chest x-ray. Then the crazy paving. So most patients with alveolar proteinosis will have crazy paving. But it turns out crazy paving itself is not specific for alveolar proteinosis because it's such a rare disease. In most cases, if you see crazy paving, it's going to be caused by something else rather than pulmonary alveolar proteinosis. Okay? So it's called crazy paving. This is the pattern of garden stones there, called crazy paving. And so there's your interlobular septal thickening, and that's what it's, somebody thought that that looks like this. So you not only get interlobular septal thickening with ground glass, but you also have intralobular septal thickening, and that's what gives you that crazy paving appearance with alveolar proteinosis. The treatment is pulmonary lavage. So with the alveolar proteinosis, they will lavage the patient to kind of wash out all of that excess protein. Okay? It can also occur from massive exposure to silica. Acute silicoproteinosis can also give you an alveolar proteinosis where they develop consolidations from that. And what are other causes of crazy paving? Well, we kind of touched on a little bit of this. What are other causes of crazy paving?
Pulmonary edema.
Sure, pulmonary edema, pneumocystis, diffuse pulmonary hemorrhage, sarcoid, mucin-producing endocarcinoma, lipoid pneumonia, all of these can give you crazy paving. Here's an example, pulmonary edema, crazy paving. Diffuse pulmonary hemorrhage, crazy paving. ARDS, crazy paving. SARS, pneumonia, even COVID can give you crazy paving. Bronchoalveolar carcinoma, crazy paving. Pneumocystis, crazy paving. So they're not specific for pulmonary alveolar proteinosis. Even an unusual case of sarcoid with crazy paving. And here's lipoid pneumonia with crazy paving. So many things can give you crazy paving. Okay, but think of pulmonary alveolar proteinosis. That's what the textbooks talk about. Okay. All right. Any questions? Very good. Next, we move on to interstitial disease. More fun.